Good afternoon, everyone. So today's topic is on penicillins. So obviously, in the last class, you know about the mechanism of action of beta-lactamase antibiotic, beta-lactam antibiotic. So can you tell me few points you know already about penicillins? Okay, how was it discovered? The history of penicillins. Okay, what he did in that experiment?
He left the yeast mold around. Culture was there, a set of culture plates where he left the mold around that is how he discovered that when he came back he discovered that there weren't any bacteria growth around
Okay.
that.
So he was having a culture of Staphylococcus culture plate he had. So what happened was when he was growing a culture of Staphylococcus, he had kept a bread along with it next to it and he forgot. So there was a fungus, there's a mold which was formed on the bread. So that had spread towards the culture plate also. And what happened was wherever the mold was present, the bacterial, that is the Staphylococcus in that culture plate had not grown. So this means that something is there in that mold that is actually inhibiting the growth of that bacteria, that is Staphylococcus. So that's how he accidentally found the penicillin. So it is something that this mold contains something called as penicillium. It is from Penicillium notatum. So that one he found it in the mold which was present in the bread. So that's why the name has come called as penicillin. Okay, so that's how and after a decade, that is in 19, this happened in 1928. So in 1940, when a mice was injected with an infection, that is with streptococcal infection, when antibiotic, that is penicillin, was given IV to the mice, it was effective. So that's how he got to know that penicillin is more effective against streptococcus and streptococcal, that is gram positive bacteria. So this is the structure of penicillin. It contains two major ring, that is one is beta lactam ring and the other one is thiazolin ring. So beta lactam ring is the one important ring that is actually the major ring for the function of the antibiotic. Yeah. So this place R, this is where there is a different function or the different chemical which is constantly added for different penicillins. Like for methicillin there is a different structure there, for piperacillin there is a different structure there. So this is the basic ring of the penicillin. Now coming to, there are many different types of penicillin. I'll send you the thing in the WhatsApp group about the different penicillin list. So penicillin majorly is divided into this one. So natural penicillin, that is penicillin G and penicillin V, and then you have penicillinase resistant penicillin. So what happened was there's something called penicillinase that the bacteria was producing to inhibit, to save itself from the antibiotic penicillin. So they found out another antibiotic which is against that. So penicillin resistant penicillin, and then it is aminophilins, that is another class, that is synthetic penicillins, and then you have extended antimicrobial activity penicillin. So penicillin was only restricted to gram positive in the beginning. So when this extended microbial activity penicillins was discovered, it covered both gram positive and gram negative majorly. So that's why it is called as extended antimicrobial spectrum. So let's talk about penicillin G and penicillin V. So it is more effective in aerobic microorganism, that is aerobic gram positive microorganism. Then it is most susceptible towards the streptococci. And penicillin G resistance nowadays is very, very high because it is used from so many years that organism have already found resistance to it. So majorly the organism which is resistant towards penicillins, that is the natural penicillins, are Staphylococcus aureus, Staphylococcus epidermidis, and Staphylococcus gonococci. Yeah, and then you have but meningococcal bacteria is still susceptible to penicillin G in few cases. So you can start with penicillin if there is a meningococcal infection, but it can be started as a prophylactic. Then coming to its stability, major disadvantage of natural penicillin is that it is degraded by acidic environment. So that was a major disadvantage of natural penicillin. In that itself, penicillin V is less degraded, whereas penicillin G had that greater disadvantage. Now coming to its functions. So which which antimicrobial, which microbial or organism is covered in that. So coming to pneumococcal infections, when there is a pneumococcal infection, penicillin G can be given, but penicillin G nowadays for pneumococcal infection is becomes, resistance is growing very high. Then coming to the pneumococcal pneumonia, that is penicillin G can be given like it can be started prophylactic, but now again resistance is increasing. But if it is still susceptible to the penicillin G, 6 to 10 million units per day can be given as a 5-day course. Then for pneumococcal meningitis, penicillin is still preferred, whereas penicillin along with vancomycin and third generation cephalosporin can be given. So penicillin dose here is 24 million units, which in a day it can be given as a divided dose or as a single dose, that is 20 million units IV per day for 10 to 14 days. Now coming to streptococcal infection. For streptococcal infection, penicillin V is preferred, that is 500 mg twice a day for 10 days. So streptococcal infection majorly caused by the organism Streptococcal pyogenes. Then streptococcal pneumonia, arthritis, or streptococcal meningitis or endocarditis, either of this which is caused by streptococci bacteria, penicillin G can be given. All this is based, it can be started as prophylactic, but after sensitivity report is come, these doses can be given. Okay, so that is penicillin G 12 to 24 million units IV for 2 to 4 weeks. If it 2 weeks for pneumonia, arthritis and endocarditis, whereas 4 weeks for meningitis. Then again for penicillin G sensitive viridae, that is penicillin G along with gentamicin can be given. Penicillin G doses 12 to 20 million units IV for 2 weeks is given. Then certain, so majorly penicillin covers aerobes. Certain anaerobic agents also can be covered, but clindamycin is more preferred, other than other penicillins are not preferred. Then staphylococcus infection. In staphylococcus infection nowadays there is lot of resistance that is happening in staphylococcus. So it is completely avoided when there is a staphylococcus infection, use of penicillins. So because staphylococcus is majorly called as penicillinase producing agents, so natural penicillins are completely avoided in staphylococcus infection. Then meningococcal infection, penicillin G high dose is preferred, that is 20 to 30 million units per day for 14 days. Then again syphilis infection, penicillin G for 2.4 million units IM is given for 1 to 3 weeks. Actinomycetes, penicillin G is preferred, again that is 18 to 12 million units per day for 6 weeks. Then for Clostridium infection, penicillin G along with clindamycin is given, 12 to 24 million units for 3 to 4 weeks is given. Then coming to penicillinase resistant penicillin. So for this you have to know what is resistance. So there are 3 major mechanisms that the bacteria will actually undergo to cause resistance. So first is enzyme resistance, that is penicillin, this beta-lactam ring usually attaches to a protein. That is, there are 2 types of protein majorly present in the bacterial wall, that is transpeptidase and carboxypeptidase. These 2 proteins, so beta-lactam actually binds to these protein so that it shows its action. So what happens is, gradually as the time progresses or due to irrational use of antibiotics, this enzyme, that is beta lactamase, which is also called as transpeptidase, that is PBP, penicillin binding protein. So penicillin binds to this transpeptidase. So this transpeptidase itself it started changing its shape. So what happens is, when it changes its shape, this bacterial ring doesn't know, this penicillin ring doesn't know where to bind for its action. So therefore, that is one disadvantage, that is changing enzyme modification process. Enzyme is there. So what happens is, there is something called beta lactamase enzyme, which is actually naturally produced by the bacteria itself. This one will degrade this part of the ring, and this ring is degraded completely. This part of the ring is degraded. So because of this, there is still no attachment towards the transpeptidase enzyme, so there is no action. Then coming to rapid efflux of antibiotics. So there is something called peptidoglycan layer, and this bacteria will allow the influx of antibiotics. But once there is influx of antibiotics, that is the penicillin inside the bacteria, there is automatic production of channels by the bacterial cell. These cells gets activated once there is an influx of antibiotics, and once this get activated, the antibiotics efflux starts happening. So these channels are mutated by the cell itself, bacterial cell, so that it sends out the penicillin as soon as it is entered. So that's how these three mutations occur. So now penicillinase is an enzyme which is produced by the bacteria itself to inhibit the the penicillin activity. So when this happened, they found out penicillinase resistant penicillin. So what happened is this this penicillinase which is present in the bacteria is degraded by here in this ring they put a chemical compound which actually degrades the penicillinase enzyme. So it is majorly used for staphylococcal infection, because as we told, staphylococcus is majorly known for producing penicillinase enzyme. So certain penicillinase resistant penicillins are isoxazoline penicillin, then aminopenicillin, and naflicillin. So this penicillin-resistant penicillin are majorly used in upper respiratory tract, urinary tract infection, and meningitis. So in upper respiratory tract infection, amoxicillin, oral amoxicillin is also preferred. That is upper limit is 40 to 45 to 80 to 90 mg per kg per day can be given in divided doses. For urinary tract, aminopenicillins is more preferred over amoxicillin. Then meningitis, ampicillin is used only when the bacteria causing the meningitis is L. monocytogenes and not staphylococcus pneumoniae, because this is more resistant towards even penicillinase resistant penicillin. So coming to anti-pseudomonal penicillin, these are also known as extended spectrum of penicillin, that is like piperacillin and all that. Even gram-negative bacteria are covered in this class. So piperacillin, P. aeruginosa and Enterobacteriaceae is covered, whereas when piperacillin is combined with a beta-lactamase inhibitor, it shows more action against E. coli, Klebsiella, S. aureus, that is Staphylococcus aureus, and H. influenzae. So all these bacteria are covered when you have combined it with a beta-lactamase inhibitor. So that is, it covers even gram-negative bacteria. These all are gram-negative bacteria, E. coli, Klebsiella, and all that. Okay, so now coming to infections where you can use this anti-pseudomonal penicillins, that is an intra-abdominal infection. If there is any intra-abdominal infection, that time you can use 3.375 grams for 7 to 10 days, Q6 hours. That is, you can use it for 4 times a day. Then community acquired pneumonia and skin infections, you can use the same dose, that is in a divided dose. Q6 hours. Then nosocomial infections, 4 to 4.5 grams in a divided dose, that is Q6 hours for 7 to 14 days is used. Now coming to the adverse effect of, that is ADR of penicillin. Most common ADR of penicillin is seen as hypersensitivity reaction. So what happens is there is something called as MDM, that is, it is a penicillinolium moiety which is produced due to degradation or the end product of penicillin. So what happens is this end product, that is the byproduct of penicillin, is penicilloyl moiety. So this one is also called as MDM. This in turn triggers the IgE mediated mechanism and it causes hypersensitivity reaction. Then if there is an hypersensitivity reaction towards penicillin, you have to cross check it with other beta-lactam antibiotics such as cephalosporins, carbapenems, and all that. You have to cross check if they have sensitivity towards the other beta-lactam ring. Possibilities are very high. Then certain anaphylactic reactions or severe hypotension can happen, bronchoconstriction, fever, nausea, vomiting, diarrhea, and all this are certain areas of penicillin. And ampicillin is more prone to cause skin rashes, that is, it is having 9% of 9% of the population had skin rashes. And Yeah, nafcillin, which is called, it causes neutropenia. It is a reversible neutropenia. It is called among 30% of the patient who are using nafcillin. So it is not majorly used in India. It is only used in some European countries as of now. Anything else?